Hello, everybody. My clinical pattern is IT band syndrome, sometimes known as IT band friction syndrome. It its demographics. It's really common in anyone who participates in any repetitive knee flexion and extension activities. So that's runners, cyclists, military recruits, rowers, skiers, anything like that. It's more common in women, but there's no age demographic that's more prevalent. It just depends on your activity generally. Outcome tools, you can use any sort of pain scale, like the VAS is very common, visual analog scale, and then you can also use the lower extremity functional scale, and that just looks at the restoration of your function after you have the onset of IT band syndrome. Generally what it is a non-traumatic stress injury. It's a microtrauma from repetitive flexion and extension knee motions. And that causes inflammation of the distal IT band because of that back and forth friction on the lateral femoral epicondyle. And the IT band and lateral femoral epicondyle are at the most contact in an area called the impingement zone, and that's at 20 to 30 degrees of flexion. And that's also the amount of flexion that occurs at heel strike. So during gait, that would be when they had the most pain. That also means that running downhill is a large factor that could cause IT band syndrome because it decreases when you're running downhill. There's less knee flexion during that heel strike of gait, which increases the ground reaction force and in the impingement zone, and will just cause more stress and friction there. The pain behavior, it's pain at the lateral knee near the lateral femoral epicondyle. Aggravating would be repetitive knee flexion and extension activities, so like running, cycling, any of those things I mentioned. Easing, ice, rest, NSAIDs. And then the 24-hour pattern depends on if it's early or later in the IT band syndrome. If it's earlier, the pain usually occurs after completing exercise, but then will go away. But when it's later, it will occur within minutes of starting that exercise. And it can occur at rest too when it's later. There are not a lot of precautions or contraindications, but I did found one that said deep transverse friction massage when it's severely inflamed, so like high irritability, is a precaution, not a contraindication. But I would just use your clinical judgment with that. For the physical exam, most of your findings will be based on which intrinsic factor is the main contributor to IT band syndrome. So that can be stuff like genu varum, excessive hip adduction, things like that. There's a list that I have too. So it kind of just depends on what that is. But active range of motion, you would expect to see hip abduction would be poor quality due to weak glutes. And then knee flexion, they would have pain in that impingement zone near 30 degrees, but extension would be normal. And then they could have excessive ankle pronation, but again, that just depends on what the factor is causing the ITBS. Passive range of motion, you would expect hip abduction to be a normal quantity, but adduction could produce pain. Knee flexion, again, would be painful near 20 to 30 degrees, extension normal, and then, again, pronation at the ankle could be excessive. Contractile unit testing, you would expect that the hip abductors would be weak and painless, knee flexors and extensors to be weak and painless. It, again, just depends on what muscle is contributing, but it could be all of those. And then manual muscle tests, you would just assess where the weak and painless findings in the CUT were and then perform manual muscle tests on those muscles. You would expect normal accessory motion, normal neurodynamics. Palpation is a big one. There's likely to be tenderness over the distal IT band near the lateral femoral condyle or over Gertie's tubercle, and that tenderness would be increased when it's palpated at 30 degrees of flexion. And then there could be trigger points in the glute med or hamstrings or quads that refer pain to the lateral knee. Special tests, the Noble compression test is for IT band syndrome. So that would likely to be positive. There also could be a positive Ober test, Thomas test, or Trendelenburg. Differential diagnosis, there could be a stress fracture at the lateral tibial plateau, lateral meniscus tear, LCL strain, biceps femoris tendinopathy, or patellofemoral stress syndrome. The diagnostic imaging gold standard is an MRI, and you would see fluid in that area between the IT band and lateral femoral condyle, or a thickening of the distal IT band. You would want to refer if pain does not go away with rest and occurs throughout activity and seems systemic. And then there are surgical options. The patient would look at surgery if they were symptomatic for over 6 months, and conservative therapies through that time was not effective. And those options would be a precutaneous release of the IT band, an open surgical release, so that's just removing fibers that are right over that lateral femoral condyle, or you could do an open IT band bursectomy to remove that bursa from under the IT band. So that is it.